today we are going to talk about a very, very interesting case in the grand round section of a case of monogenic obesity. Now, obesity is something which we see right day in and out, but most cases do not have a genetic etiology. In fact, most of them don't even have an underlying pathological cause. But there are certain disorders in which you can have a lot of genetic component, and that can have significant implications in terms of diagnosis and management. So we'll be illustrating index case which will really highlight about the complexities of assessment and how difficult it may be in terms of evaluation and management from that perspective. So I'll just start off with this initial case which we saw some time ago. This is a 3-year-old girl with rapid weight gain, and what we found in this scenario was that there was height was 84, but the weight was quite significantly elevated to 26 kilograms. There was severe hyperphagia since birth, and this is something which we need to understand, that if you have an early onset syndromic features, especially hyperphagia, that becomes a significant scenario we have to look at. So this was an early onset obesity in which what we are seeing is that there is hyperphagia which was there. Basic workup was all normal. Everything was normal. There was no developmental issue, vision, infections. And normally we say that if a child has a normal growth, puberty, development and eyes, we consider it to be an exogenous or constitutional obesity. But if its onset is too early, we have to think of a possibility, and this child was found to be a leptin deficiency in that regards. Identification of this will have implications in terms of treatment options availability, in terms of pubertal issues, in terms of immunodeficiency issues, which may happen subsequently in that regards. So obesity overall is quite common in the population, around 10 to 15%. 98% of it is exogenous, and genetic causes is definitely less than 1%. Even if we talk about selected individuals in the first 5-year or first 2-year bracket, the prevalence is less. So before 3 years of age with hyperphagia, still 5 to 10% will have genetic cause. So it's not an exceedingly common cause, but if you identify, you have a lot of implications which we need to evaluate and other perspective. Syndromic obesity, of course, is an important chunk. We are not going to discuss about syndromic obesity. We are talking about single gene disorders which do not typically cause any dysmorphism in most scenarios, and it has implications on treatment and prognosis, which we'll discuss about from that regards. All of you can go and have a look at our website, learning.rososociety.in, wherein we have got a lot of e-learning portal, including our YouTube channel, our website, which has got a lot of tools related to pediatric endocrinology, including fellowship and postgraduate courses. We do run grand rounds, PG lecture series and journal clubs frequently, and our publications are there, and the mobile application which can guide on. Latest of it is our obesity interpreter, which will be quite relevant from this perspective, which allows when to think of a genetic cause, and that's been accepted for publications. The medial basal hypothalamus, which is the main regulator of appetite, and here we have got the two key pathways which are there. We have got the central processing unit, which comprises 3 major nuclei: the ventromedial hypothalamus, the arcuate nuclei, and the nucleus tractus solitarius. There are the anorexic pathway, which basically tells us we have eaten a lot and spent more energy, through the POMC cart pathway, and the orexogenic pathway, which say that we need to eat more and don't want to spend a lot of calorie, through the AGRP, neuropeptide Y pathway. The major signals that are coming through them include the mechanistic signals which come from the stomach via the vagus. So if the stomach is empty, you will get a signal that you want to eat. There would also be a signal of ghrelin which will tell the food should come. Then, of course, we have got the nutrient signals which are going to control that. The major nutrient signals, of course, include the GLP, which we talk a lot about in terms of pharmacology, insulin, and then we have a major player of leptin, which is regulating a lot of process. And leptin can be considered as a status symbol of what our nutritional or energy status effectively is. And of course, from there, we have got the efferent pathway, which regulates the sympathetic activity from that regards. The leptin, POMC, MSH, MC4, BDNF pathway is central to the whole process. So it's all part of the chain. And if you remember this, most of the genetic etiologies, the monogenic causes, will come up from that in that regards. So we have got leptin, which acts on the POMC neurons to produce POMC, which is then cleaved via the proconvertase and carboxypeptidase into MSH. Of course, you also have ACTH coming into that, endorphin coming to that, and MSH acts via the MC3, MC4 receptor in the paraventricular nuclei and lateral hypothalamus to then subsequently stimulate the brain-derived neurotropic factor BDNF in the ventromedial hypothalamus, which again uses a TRKB receptor to cause decreased appetite and increase energy expenditure. So the overall anorexic pathway is asking us to eat less and spend more. You need to have everything in check. So if there is a problem in leptin, problem in POMC, POMC activation, MSH receptors, BDNF or TRK, you will have a monogenic obesity. Now, most of these, except for BDNF, do not have any significant syndromic features. So that's why we talk about syndromic versus non-syndromic from that perspective. So monogenic syndromes can be part of the leptin POMC pathway, problems in the MSH receptor, MC3, MC4 receptor particularly, and the BDNF pathway. We'll be focusing predominantly into these, which are the major cause. The most common cause, of course, is considered to be the MC4 receptor, which is an important cause in that regards. So leptin deficiency was one of the first causes of monogenic obesity which was reported. It is an autosomal recessive condition, first reported in a Pakistani individual in consanguineous family, very early onset of severe obesity, recurrent infections, and there was later on pubertal delay. With leptin treatment, there was a dramatic improvement which was there. The manifestations, of course, are a very severe hyperphagia and food foraging, and because leptin is very important for growth hormone secretion, despite being obese, these individuals are not tall. Everybody who is obese should be tall, but leptin deficiency will be normal height or short in that regards. Because leptin is essential for puberty, they will have delayed puberty. They will also have this plus minus central hypothyroidism like picture, and immunity is also compromised in that regards. So they are normal growth development, or in fact they may be short. So it may be a feature which is there in that regard, may also develop infections and steatosis later on. Management, of course, is with metreleptin, which is effective but it's quite expensive and not easily available. It improves hyperphagia and satiety in that regards. Leptin resistance is the default mode in obesity. Now, once leptin was discovered, everybody thought that we can give leptin and there will be a wonderful drug to treat obesity. But what people realized is that most obese individuals are leptin resistant because their leptin levels are high, and because of this resistance, they are basically having these problems. So probably the answer is leptin sensitization, although that's not very easy to achieve. So most obese individuals will be having high level of leptins. So while low level of leptin will be of importance in monogenic obesity, suggesting a leptin deficiency, higher level do not suggest a leptin resistance. You need to go for a genetic test here in that regards. So again, leptin is high, starvation response is there, so there will be hypothyroidism, there will be pubertal delay and short stature. So early onset severe hyperphagia, again all the similar findings as leptin deficiency, the features will be milder because some amount of action is there. Do not measure leptin levels in this scenario, better to go for genetic testing. Management, of course, is difficult, and we'll talk about how all the pathways which are proximal to MC4 receptor, whether it is leptin receptor, whether we have POMC, whether we have a MC4 receptor defect, we may consider setmelanotide, which is the MC4 receptor agonist, which we'll talk about a bit later from that regards. Now, the defect that we're discussing about in this case, which Alapan has already discussed about, is a problem in the pro-opiomelanocortin, and it could be both heterozygous and homozygous, deficiencies of ACTH, MSH, and endorphins. Manifestations are early onset hyperphagia, ACTH deficiency, variable pigmentation, and as discussed, hypothyroidism may already be there. And very importantly, because of the important role of MC2 and MC4 in maintaining the blood pressure, autonomic features are also common, and they may develop unexplained hypotension, and they are supposed to respond well to MC4 receptor agonist. Proconvertase is a phenocopy of POMC defect. Essentially, you are not able to cleave POMC. So you will have problems in that. In addition, where all you want to cleave the peptide, particularly insulin, particularly AVP, the problem will also be added. So the defect is in impaired splicing. You will have problems in multiple hormones who are produced as pre-pro. So pro-opiomelanocortin, pre-pro AVP, pre-pro GnRH. So all of them cleavage will be difficult in that regards. You will have again similar findings with ACTH deficiency, diabetes insipidus and diarrhea, and hypoglycemia because of high levels of proinsulin, because it's not being able to be broken down from that regards. MC4 receptor, of course, is the site where MSH is acting. It is the most common cause, at least in the Western reports, is the most common cause of monogenic obesity, and they have high level of insulin resistance. And because of that, they are tall. So if you have a very early onset of obesity with tall stature, MC4 receptor is the thing that you're looking at. And they also have a problem in the autonomic functions because the receptor is not working. It is again difficult to treat. In some scenarios, they may respond because if the receptor defect is responsive, you may respond to setmelanotide. Otherwise, bariatric surgery becomes the only option. BDNF is subsequent to the MC4 receptor. So this is one condition where setmelanotide is not going to work. The defect, of course, also has other features of neural involvement. So a number of syndromes are associated with these conditions: hyperphagia, developmental delay, and hyperactivity and learning disability. So to summarize, leptin defect causes early onset hyperphagia, delayed puberty, short stature, immune problem. Treatment is leptin. Leptin receptor, again, milder form treatment could be MC4 receptor agonist, POMC, ACTH deficiency, central hypothyroidism, depigmentation, hypotension, PCSK, multiple endocrine abnormalities, including that of POMC, along with insulin and diabetes insipidus, MC4 receptor, tall stature, and insulin resistance, where surgery is recommended. And BDNF is more of a neurological, so it's more like a syndromic cause rather than a monogenic non-syndromic forms of obesity. So when should we think of a genetic obesity? So as I always say, for any genetic cause, you need to have 4S: soon, between below 2 to 5 years of age, severe, segregating, that is the family history or family history of consanguinity, and finally syndromic features like hyperphagia, developmental delay, visual problems, or neurological features. So any of these, think of a genetic obesity. So our approach basically, of course, is to look at the features of growth, puberty, and onset. If everything is normal, it's exogenous. Slow growth suggests endocrine. Early onset less than 5 years, we then go classify based upon the development, dysmorphism in vision to identify syndromic causes. If they are absent, in that scenario, we probably most likely go towards the genetic analysis. And now probably we should not even do leptin. We can directly go ahead with the NGS because that may be more reliable and easily available from that perspective. So once you have excluded the common endocrine causes, once you have excluded the hypothalamic obesity and syndromic causes, go for NGS. If you're looking for a syndromic cause, then you go for NGS with MLPA to look for Prader-Willi syndrome in that regards. So 3-year-old girl with rapid weight gain, Dr. Alapan, height 84. We've discussed the severe hyperphagia since birth and normal FT4. Everything is normal and no other problems. What will you do here?
The early onset of obesity with severe weight gain is there, and rest of the all investigations are normal and development vision, these are normal. So we need to go for a genetic study.
So we should go for the genetic analysis, and at that time we used to do leptin, but ideally we should go for a genetic test in that regards. 2-year-old girl with weight 24 kgs, rapidly progressive hyperphagia. Would you like to do a genetic diagnosis here, Nimisha?
So we will initially look for any syndromic features.
So there are no syndromic features?
No visual or...
No visual problems. So do you think it merits a syndromic genetic cause evaluation?
We need...
So it is soon, 2-year-old, it is severe, it is syndromic hyperphagia. There's no family history, but that's when you need to evaluate, and that echoes with most of the international guidelines like the Endocrine Society and the IAP guidelines about genetic obesity. 4-year-old boy with hyperphagia, height is 114 centimeters, weight is 28, normal development and vision, what are you thinking of?
Age is less than 5 years here.
Hmm.
Severity is high because at the age of 4 years,
And height is?
and the height is a bit taller on the side actually for 4 years of child. So early onset obesity with a tall height, probably a monogenic obesity due to
So look for acanthosis because they have a lot of insulin resistance. And once you do a further workup, you will be able to find a MC4 receptor defect in that regards. So now what could be the therapeutic options that are there? The options could be if there's leptin deficiency, you can give leptin. Beyond that, whether it's a problem in the leptin receptor, problem in the POMC, proconvertase, or even at the MSH MC4 receptor, you can use MC4 receptor agonist, which is setmelanotide, which is basically a selective form. So it's a G alpha Q selective. Why do you want this? So why do you want selectivity for MSH? So what does MSH do other than pigmentation or let's say appetite control? One thing we talk commonly about people who have problems in POMC or MSH is what is the effect on blood pressure? So if you have a functional form, it will cause hypertension. So setmelanotide is selective one, which is non-hypertensive. That is the biggest advantage, which is there from that regards. And this is going to decrease your appetite. Other options would be if everything else is gone, you can use either lifestyle, metformin, or surgery is the treatment in that perspective. So recombinant leptin, this is the first study from Dr. Faruqi's group. You can see the massive obesity, and after leptin, there was a dramatic fall. So there is an improvement which happens very quickly, and you are seeing that the weight from 95 is going down somewhere around 80. So in 12 months, decreased by around 15 kg. So typically, most obesity therapy, we are talking about 10 to 15 kgs a year. Setmelanotide is a bit more in that perspective. So there was a good response, but it is restricted to deficiency because most non-syndromic, non-genetic causes have leptin resistance. So giving leptin there will not be of much benefit, very importantly. Now, MC4 receptor defect in this condition, this is going to be talked by Alappan more. Also, you can see dramatic effects. So weight change, you can see, is going up to the tune of minus 60 kgs also. So this is huge decrease in terms of the weight in patient 1. Patient 2 also 40 kgs. So you can see that there is a dramatic improvement in that perspective. So there is a definite potential in POMC, PCK, leptin resistance, and MC4R. There are people who have also considered whether we can consider them for normal individual also, because this is again a drug which is going to induce satiety. But compared to this, we have got now GLP-1 analogs which are supposed to do better from that perspective. So MC4 receptor agonist, this was a study for setmelanotide in that group. What you are seeing here is that the weight was 130 to begin with, and day 29 there was a 3 kg loss, already 3.4 kg loss which is there. What was interesting here was that even for the controls, there was a 3 kg loss. So which means this is a good drug in terms of efficacy, but still it is not very, very commonly used from that perspective. It is restricted for that because it has got more side effects. It is a centrally acting drug. It causes pigmentation. There's so many other things happening from that regard. So this is something to look at from that regards. So now, Dr. Alappan, you can carry forward with regards to the treatment of this particular case. What are the options available?
Thank you, sir. So the treatment options available, one I have discussed already, that the nutritional management we can do, that we are doing right now. Secondly, for the central hypothyroidism part, we are prescribed thyroxine in this child, and the child is taking regularly for the hypothyroidism. But the other option, as the genetic report has in our hand, and right now we can prescribe for the setmelanotide. That is a MC4R receptor agonist that Sir has already described about it. It is recommended in the NICE guidelines that it should be used around people of more than 6 years of age with genetically confirmed POMC pathway, PCSK1 defect, or leptin receptor defect cases. It's supposed to increase the weight, BMI, hunger score, quality of life, And it is a subcutaneous injection, and that is usually started on the dose of 0.5 to 1 milligram and can go up to 2.5 to 3 milligram depending on the age. And as Sarah has already described, that this drug doesn't have potential to cause hypertension as seen in the previous group of MC4R receptor agonists. So this case, Sarah has already described. It was published in New England Journal of Medicine. 2 patients had been taken. One 21-year-old lady from Germany, and another one was 26-year-old lady from France. As you can see, at the age of 18 years, their weight was way above the 97 percentile in this case. But after the starting of the therapy, as in the initial 15 weeks, we can see a significant weight loss of around 25 kg in the first patient and similar in the second one in the first 5 weeks. Also, they have seen for the hunger score in a Likert basis hunger scoring, and they have seen that there is also decrease in the hunger score in this patient, which increases the quality of life in this patient. The dip in around the 15 weeks, the treatment was stopped there somehow. That is why there was again a significant weight gain. So that is a question that whether after stopping, how long we have to give
a replacement.
Yes, we have
So
to
if there's
continue to
deficiency,
lifetime.
they'll always gain weight. So this basically, like when you're using GLP-1, it is not like you are treating deficiency. It's not like giving growth hormone for GHD. It's like giving it for somebody with SGA. You're treating somebody who doesn't have the defect. Here they have a defect. So you can see the dramatic response if you look at this child at 40 weeks, which basically would mainly mean somewhere around 7 months. There's losses around 50 kg,
50 kg, yes.
which is unheard of. The second case, you're looking again 20 kg in 10 weeks. So which means 2.5 months. So it's like a huge loss. But definitely if you stop it, they're going to gain again. There's no way out.
And moving on to the glucose tolerance part, that initially the insulin resistance, as we can see from the black curve in the left upper initially it was so high, but after using the drug, in the both patients, the insulin resistance has been decreased. There is no significant difference in the blood pressure, systolic blood pressure, diastolic blood pressure, or heart rate, or any autonomic dysfunction in both of the patients. So up to 2021, these things has been published. And the one interesting fact that in the 10th patient, it is an Indian patient, and still I don't know whether they have a retrospective or something. They have found that skin and hair are lighter than the expected in Indian population. So probably, and other some features of central hypothyroidism are present. Growth hormone deficiency, type 1 diabetes is very common, not very common, but it is present in some cases. And the hypothesis that has been postulated that probably autoimmune mediated type 1 diabetes is present in cases of POMC defect. So we have to look for the other autoimmune association in the future long. So these are the case. These are the patients. And the last thing, it is not associated with POMC or MC4 defect. This tablet diazoxide choline has been recently approved by FDA for the hyperphagia part of the Prader-Willi syndrome. And as we know that diazoxide choline is basically nothing but a salt form of diazoxide, which also acts on the hypothalamus on the agouti-related peptide pathway to decrease the hyperphagia in Prader-Willi syndrome. So can that it be a potential tool, since it is an oral tablet, once a daily tablet, and so can it be a potential treatment for in the future?
There have been a lot of talks about oxytocin earlier, also inhaled oxytocin as a treatment of choice, but that doesn't seem to have come up. So we'll have to wait and watch how it progresses. Often drugs come and go. Like when leptin came, everybody thought that leptin is going to be the weight loss drug, but it didn't work at all. So let's see how it goes. But yes, if you have precision medicine, like if you are able to get POMC for this patient, it will be dramatic. MC4 receptor agonist setmelanotide will really change in that regards. Thanks a lot, Alström, for a wonderful discussion and interesting case. So again, the big message is that if you have an early onset obesity, in a child, you need to be very careful and consider a genetic possibility, and which can open up avenues for treatment. All of you can go and have a look at our books which are available online, including our applications and our courses which are available in our website. So we will now be looking off if there are any particular questions which are there. Dr. Adelaide is asking, is the high TSH the consequence of obesity or the cause? In this case, the TSH is not appropriately high. It is actually should have been much higher if the FT4 is low. So here it is the POMC defect or the MSH defect or whatever is going to cause the central hypothyroidism like picture. In obesity, it's the other way around. Dr. Adel is saying, why in the workup investigation the cortisol? So the answer is that we are looking for cortisol deficiency. Of course, if somebody has central hypothyroidism, we have to do cortisol. But again, also in somebody who has early onset obesity, POMC is a possibility. So you should always look for cortisol in that regards. Cortisol should be measured in early onset obesity. It becomes important from that.